As a first step in clarification, let us chart the various degrees of malnutrition from the standpoint of relative severity. Let this line represent the normal tissue concentration of the vitamins. The normal tissue concentration of any of the vitamins. Let this line represent a mild deficiency. A mild tissue deficiency of any of the vitamins. Let this line represent a severe tissue deficiency. A severe tissue deficiency of any of the vitamins. To illustrate, let us take a mild ascorbic acid deficiency. If that mild ascorbic acid deficiency occurs over a short period of time, such as this, we will have developed then a mild acute scurvy. On the other hand, if the tissue concentration falls to this level, but over a long period of time, months or years, then we will have in this patient a mild chronic ascorbic acid deficiency or scurvy. Now let us illustrate the severe deficiencies by niacin deficiency or pellagra. If the tissue concentration falls over a short period of time to this level, we will have an acute severe pellagra or acute niacin deficiency. On the other hand, if the tissue concentrations fall to this same level but over a long period of time, then we will have a patient who shows a chronic but severe niacin deficiency. In other words, a chronic pellagra. Here is a patient who exhibits the signs and symptoms of an acute severe niacin or nicotinic acid deficiency. The stupor, the sucking and grasping reflexes are the only outward expressions of the ailment. Superficial examination of the tongue, the mouth, the skin reveals nothing of diagnostic importance. Yet the therapeutic response of this patient to niacin is almost as rapid as the response of a patient in diabetic ketosis to fluids, salt, and insulin. When the depletion of niacin in the tissues has not been as severe, there appear the ordinary signs of pellagra, the red tongue, stomatitis, and dermatitis. This is ordinarily called acute pellagra, but in reality represents subacute severe niacin deficiency. Various other combinations are possible. For example, a mild chronic deficiency may have superimposed upon it an acute deficiency. The pellagra here illustrates such a situation. When first seen, this patient had the satiny smooth glossitis and the dermatitis of a chronic niacin deficiency. Following abdominal surgery, failure to eat, and glucose infusions, the stupor and the sucking and grasping reflexes developed. They are signs of a severe acute niacin deficiency. Treatment of this case with niacin has to be modified as a result of the development of the severe acute symptoms. With adequate dosage, and this means large dosage, these severe acute symptoms will probably respond to therapy in 2 or 3 days. The mild chronic symptoms, on the contrary, respond very slowly. The pigmentation of the hands and the flattened papillae of the tongue takes months to respond. The principle demonstrated in the case of niacin applies to practically every nutritional deficiency. As another example, look at this case of severe acute scurvy. Now in this first case, an acute severe deficiency, the tissue changes are largely represented by hyperemia, hemorrhage, and edema. Our experience with cases of this type makes it possible to predict with full assurance that with adequate dosage, 500 to 1,000 milligrams daily, the outstanding symptoms in such cases will disappear in about 72 hours and the gums shrink to almost normal position in about that time. With almost equal confidence, it can be predicted that this case of mild chronic ascorbic acid deficiency will show slow response to therapy. The tissue changes are a response to a chronic deficiency, even though mild. Hypertrophy or atrophy of the tissue has time to develop, and response to therapy is very slow. For those who are inclined to take the diagnosis of deficiency states casually, it should be pointed out that we are faced simultaneously with one other problem, the problem of multiple deficiencies. One must acquire a facility for identifying the more common lesions of malnutrition. Let us see and name some of them. You examine first the eyes. With malnutrition known or suspected, you look for changes in the conjunctiva. This eye shows a typical xerosis conjunctiva. Note its position in the equators at either side of the cornea. It is usually more marked on the nasal side. Not all spots appearing in the conjunctiva on either side of the cornea represents xerosis conjunctiva. Some are synechii, and some are scleral deposits of varying composition. This lesion, being chronic, requires months of vitamin A therapy. These two eyes, before and after, show the results of vitamin A therapy after persistent treatment for months. Note that the spot may appear more prominent after treatment due to thinning of the conjunctiva around the spot. In addition, the blood vessels in the sclera may also appear more prominent due to this same thinning of the conjunctiva. The next thing to look for in the eye is corneal vascularity. One needs either the biomicroscope and slit lamp or the small hand slit lamp. This corneal vascularity may be due to riboflavin deficiency, but light or other trauma or even other diseases may produce corneal vascularity. So one again is confronted with making a differential diagnosis. If the patient gives symptoms of burning, itching, tired eyes, and they respond fairly rapidly to riboflavin therapy, one may postulate the diagnosis of riboflavin deficiency. In this eye, one may see corneal vascularity, but without the symptoms of itching, burning, and eye fatigue. Response to riboflavin is slow, and in many, if not most subjects, little response may be obtained in a year of therapy. This may mean either that the corneal vascularity was not due to riboflavin deficiency, it represents a relatively irreversible lesion. We come now to the mouth. In this patient, the lesions at the corners of the mouth are typical of the chylosis of riboflavin deficiency. Not all fissures in the angles of the mouth are due to a lack of riboflavin. In elderly patients, one often sees little fissures and cracks in the corners of the mouth. The lips cave in. She opens her mouth and one discovers the reason. Her need is not primarily for riboflavin, but for some serviceable dentures that she'll keep in her mouth and use. Now let us go to the tongue. Two deficiencies are manifest in this organ. The most common is niacin deficiency. The earliest signs are red, swollen, fungiform papillae. As the deficiency continues, the filiform papillae also become red, giving the scarlet red tongue. This tongue shows what to expect in severe acute deficiency of niacin. This is the scarlet red stomatitis of pellagra. The other extreme, as represented by this tongue, is that of a mild chronic niacin deficiency. See the atrophy? The papillae may be mushroomed out, but are not so intensively red. They may show fusion or atrophy, and if this has gone on over several years, you see fissuring, giving a geographic or scrotal type of tongue. These tongues may or may not be associated with pernicious anemia. In any case, they often respond to niacin over long periods of time. This is not to infer, of course, that all tongues showing geographism or scrotal distribution of the fissures are due only to a niacin deficiency. Many, possibly most, do respond to niacin. Others are congenital, and still others may be the result of lichen planus or other independent mouth lesions. In riboflavin deficiency, the tongue, instead of being red or coated, may develop a purplish or magenta hue. Some observers have stated that pyridoxine deficiency will produce this same appearance in the tongue. Now the gums. Let us briefly refresh our memories as to how healthy gums appear. Note the pointed intradental papillae. Note the healthy pink color of the gingiva. There is no rosacea or marginal redness. And now for contrast, we have here the acute lesions of scurvy. As previously stated, when we give adequate doses of ascorbic acid, the gums will seem almost to melt away as they return to their normal position and contour. Lesions of mild scurvy are less definite. Also, what role infection and calculi have to do with the production of these signs is not clear. It is probable that ascorbic acid deficiency is the conditioning factor for many changes that occur in the gums, but by no means all. For example, in this case of Vincent's infection, the primary diagnosis, based upon the presence of the scarlet red stomatitis, is niacin deficiency. If specific therapy, in this instance niacin therapy, is instituted, not only will the scarlet red stomatitis be blanched within 24 to 48 hours, but the Vincent's infection heals without other general or local therapy. Certain deficiency signs in the skin should be familiar to every physician. The dermatitis of pellagra, for example, although more common where the disease is endemic, may be seen in patients in any section of the United States. Typically, as in this patient, the lesions appear on the exposed parts of the backs of the hands, wrists, and forearms. It may appear on the neck or about the ankles. It is usually symmetrical. The areas may progress to ulceration, desquamation, and cracking and bleeding. Sunlight enhances the discomfort and the burning sensation. The skin lesions associated with scurvy are the petechial or parafollicular hemorrhages, often on the lower extremities or in areas where the skin is subjected to pressure. A number of observers have described various skin lesions which disappear after the administration of the whole vitamin B complex. Some of these lesions are of the nature of a chronic or acute eczema. Signs of vitamin A deficiency are often observable in the skin. Here we see the hyperfolliculitis of vitamin A deficiency. Now we shall consider the neurologic manifestations of malnutrition. A diagnosis of mild polyneuropathy may be made when neurologic examination discloses the following signs. Calf muscle tenderness. The healthy calf muscle, if squeezed from behind so as not to include the tibia in the grip, can tolerate considerable pressure before pain is felt. Pain occurs in the presence of a mild vitamin B1 deficiency, as this patient's face indicates. Plantar hyperesthesia. We refer here not to the ordinary tickling sensation usually elicited by scratching the undersurface of the foot. Plantar hyperesthesia is a very definite hyperesthetic pain produced by drawing an object firmly but not ungently over the bottom of the foot. How uncomfortable this becomes can be judged by the patient's facial reaction. If there is a mild polyneuropathy, vibratory sensation, tested with the C256 tuning fork, becomes diminished. These three signs, calf muscle tenderness, plantar hyperesthesia, and diminished vibratory sensation, do not establish a positive diagnosis of polyneuropathy due to a general or systemic nutritional deficiency, since circulatory disturbances may cause these or similar findings. If, in addition, the ankle jerks are absent, a diagnosis of mild polyneuropathy should be made. Note that the ankle jerks are absent in this patient. A diagnosis of moderate polyneuropathy may be made when knees and ankle jerks can no longer be elicited, but positive signs are still limited to the lower extremities. We shall see how this applies in this patient. Impairment of position sense in the toes is now quite definite. The gait is now frequently affected, and the burning sensation, often noticed earlier but now quite acute in the soles of the feet, plus diminished position sense, may compel these patients to walk carefully, as if barefoot on a floor strewn with tacks. Calf muscle atrophy is now very obvious. Toe drop and foot drop are also plainly evident. Wrist drop soon appears. Walking, virtually impossible, is of the steppage type. As in thiamine deficiency, objective signs of niacin deficiency are often preceded by mental symptoms. These symptoms involve all forms of sensation, increased psychomotor activity, definite trends toward depression and apprehension, and weariness, fatigability, headaches, and insomnia. In patients with classic pellagra, The mental symptoms commonly seen are those found in any organic psychosis. They include memory defects, disorientation, confusion and confabulation. Periods of excitement, depression, mania, delirium, and paranoia occur not infrequently. These mental disorders may appear before other signs of pellagra are evident. If the psychosis has been of short duration, response to treatment with niacin is usually prompt. Referring once again to our chart, it may be pointed out that from the standpoint of niacin deficiency, the pellagra syndrome of stomatitis, mental symptoms, diarrhea, and dermatitis represents a chronic partial deficiency of nicotinic acid. When the availability of niacin is suddenly reduced and the restriction is virtually a complete deficiency, structural changes may not have time to develop, and a fairly characteristic neuropsychiatric syndrome occurs, which has been called nicotinic acid deficiency encephalopathy. In endemic pellagra, the encephalopathic syndrome occurs only in the most advanced and severe cases. The syndrome may occur as the only clinical manifestation of a deficiency disease, or it may occur in association with polyneuropathy, scurvy, or ariboflavinosis. We may thus have an acute, severe niacin deficiency superimposed upon deficiencies of almost any degree of the other water-soluble vitamins. Nearly every one of the patients we have studied had a multiple deficiency. This must follow by necessity when we consider the fact that neither primary dietary failure nor conditioning factors are as a rule selective of any one vitamin. With the possible exceptions of vitamins D, E, and K, there can seldom be a diagnosis of a single vitamin deficiency. Seidenstrecker, Williams and Wilder, Smith, McLester, and other investigators have observed and described subgross multiple deficiency states, sometimes loosely grouped as a neurasthenic syndrome. Such deficiency states no longer need remain in the dim realm of the subclinical or subgross. With the diagnostic methods now at hand, it is often possible to eliminate guesswork and opinion and to place our diagnosis upon a firm, objective basis. And now back to our conference.